All right. So, hello everyone. My name is Iman Khwaja Reddick. We are pleased that you could all join us for this week's lecture in Volume 8 of the KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. We would like to thank our 2023 sponsors for their generous financial support of this series. Additionally, we are grateful to our International Neuropsychology Society colleagues for their sponsorship and wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It will be held in New York City from February 14th through the 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on the YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to its new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Lana Harder for today's lecture titled Increasing Access to Care for Kids Through Tele-Neuropsychology. Dr. Harder leads the Neuropsychology Service and Neuropsychology Training Program at Children's Medical Center. She holds dual faculty appointments as Professor of Psychiatry and Neurology at UT Southwestern. Dr. Harder is board certified in clinical neuropsychology and is a board certified subspecialist in pediatric neuropsychology. Nationally, Dr. Harder was elected president-elect of the Association of Postdoctoral Programs in Clinical Neuropsychology, or APPCN. She has served on the board of directors of the American Board of Clinical Neuropsychology and 2 consecutive terms on the board of directors of APPCN. She also serves on the board of directors and medical and scientific council of the Siegel Rare Neuroimmune Association. She's also a fellow of the National Academy of Neuropsychology. Dr. Harder earned her doctorate from the University of Texas at Austin and completed her predoctoral internship at the Kennedy Krieger Institute and Johns Hopkins School of Medicine. She completed postdoctoral fellowship at Texas Children's Hospital and Baylor College of Medicine. Dr. Harder has served as a pediatric neuropsychologist at Children's Medical Center since 2008. She was a founding member and is the current co-director of the Children's Medical Center Pediatric Demyelinating Diseases Clinic. Inspired by her work evaluating children with rare disorders, Dr. Harder published the first study on pediatric tele-neuropsychology. Dr. Harder, we are so excited to have you, of all people, discussing tele-neuropsychology since you're a pioneer in this area. So I'm going to go ahead and turn it over to you.
Thank you so much. I really appreciate this invitation. And I'm delighted to get started. Let me share my screen here. Right. So thank you for that wonderful introduction. As you noted, a lot of the work that I've done in demyelinating disorders really led to this work in teleneuropsychology, just due to the rarity of those conditions and our efforts to want to reach our patients wherever they were in need of specialty care. So I'll talk about that more. I do want to share disclosures as we get started. So I'm an employee of Children's Health. I'm on the faculty of UT Southwestern here in Dallas. I have received consulting fees from Ionis Pharmaceuticals and research support that is very relevant to today's discussion from the Children's Trust and National MS Society. So as we get started on this topic, discussing telehealth and teleneuropsychology, I want everyone to take a moment to consider some really interesting statistics. That is that only 7% of neuropsychologists practice in rural environments, and over half of all neuropsychologists practice in 9 states. So when we think about accessibility, I think this is a really important piece of information to consider, that neuropsychologists are not everywhere, right? We're not at that point in the field where we have, have our folks distributed around to be able to reach everyone that needs us. And I think that teleneuropsychology provides some really exciting opportunities to reach our patients wherever they may be. I wanted to share this. As you can see, this is the state of Texas. That red dot represents my hometown. I grew up in a town of less than 5,000 people in rural East Texas. And so I really, as a person growing up in a rural setting, and even remaining in touch with my friends and family who are still there, I can really appreciate and have seen the lack of access there is to specialty care. And so I wanted to highlight that piece as well. This is a topic that has become near and dear to my heart for both professional and personal reasons. As we talk about telehealth services today, I just want to acknowledge that there is a whole range of ways to accomplish this, different things such as, modalities, phone, video conference, text message. Today, we're really going to be focusing on that video conference piece. But this broadly is how we provide care remotely by means of telecommunication. There's certainly been some great work on phone-based services, but I won't be getting too much into that today. More thinking about the video conference, right, with a little bit like Zoom is, so we can see our patients on the screen and have a face-to-face visit with them. So in Dallas, as I've mentioned now, we were, in a clinic taking care of kids with rare disorders, and we really wanted to promote access to the specialty care that we provide. We have a multidisciplinary team. And so our goal was to establish tools to evaluate patients from a distance. We know that there are many benefits to telehealth. We've talked a little bit already about access. A lot of what we'll talk about today really centers on that. Reducing barriers to our patient families. For these patients coming to see us in the previous slide, I should mention those red dots represent the states where our patients were traveling from to see us in Dallas. So at some point, we've counted over 30 states, and sometimes they're coming from outside the country. So we know that there is a real burden on our families to travel to see us, to get lodging, childcare. They're missing work, school. There's a lot going on for our families. And for those who may have a disability, navigating travel in that context can also be a challenge and a barrier. We have seen some information to suggest that using telehealth improves our show rates, and we can limit trips to clinic for those who are immunocompromised. So that becomes very relevant when we talk about a global pandemic, but is important with or without a pandemic. And then, as researchers, we also think about telehealth as a way to facilitate data gathering, which can be very helpful when you're studying rare disorders. So I put previous problem. I think that we're still growing in our literature, so I don't mean to suggest that one study could, solve the problem. But when we were looking at this originally, we noticed there were no published teleneuropsych studies in pediatric cohorts, and there were no home-based studies at all in adult or pediatric samples. So we also were appreciating that we didn't know how this would be for our patients and their caregivers when it came to satisfaction. So we were interested to know, what they thought about the service after experiencing it. We did have some tele-assessment work that had been done with kids. And as you can see in the slide, I won't go into all of the detail, but this was using the CEL4 and the WISC-5. And these researchers used a methodology that was pretty different from what we used in our study, so that they administered these measures at a single point in time, and then they had raters, with the child and also remotely. But overall, their findings were pretty promising. There was some strong inter-rater reliability when those who were kind of co-scoring compared the results that they were seeing, again, whether in person or remotely. So that was really nice to see in the literature. And so we set out to examine the feasibility of a home-based model working with kids specifically. And as you can imagine, there could be a lot of challenges to that, to testing children remotely. And maybe we'll get into some of this as we talk today, especially in kind of the Q&A. But I want to be sure I'm mindful of time and that I kind of share the highlights of what we learned. But we wanted to determine if results differed between remote neuropsych testing compared to that traditional face-to-face testing, and then look at satisfaction with this telehealth model. So we recruited from our neurology clinic for demyelinating disorders. So vast majority of our participants came from that clinic. And then we had a smaller subset that came through a family camp for pediatric patients with multiple sclerosis. And what this looked like is they participated in two 90-minute sessions. One was face-to-face and one was remote from their home. We did counterbalance the order of sessions. So about half got for a face-to-face session first, and about half had the remote session first. Mean days between those sessions ranged quite a bit, from 1 to 50 days, but the mean was the mean was 16, but the range was 1 to 50. So wanted to share our battery so you could see this. This battery was really designed thinking about kids with demyelinating disorders and areas that are vulnerable for them. So you can see we have a number of measures looking at processing speed. We have some fine motor based things, attention, executive function, memory. And we also got a snapshot of some academic skills as well. So we actually enrolled 94 participants, and I think it'd be rare to ever see 100% complete this study. So we had a completion rate at 62%. So our final sample was 58. We had 27% lost to follow-up. I'll elaborate on that later. And then 11% that were incomplete. So they completed one visit, but not the second one. So these are the demographics for our sample. So we had a pretty wide age range. You can see 6 to 20 years with a mean age of 13. Great question I've had over time is, what percent of those were on the younger side, so 6 to 12? So just less than half at 40%, and then 60% were more of our teen and older age range. We had 62% female, which we believe is a bit reflective of what we see in demyelinating disorders. So that was probably a factor there. In terms of race, 85% were white, 5% Black or African American, 3% Asian, and 7% other or unknown. And for ethnicity, we had 43% were Hispanic, and 16% of the caregiver primary language was Spanish. We did have all of our consent forms and things translated into Spanish to allow for for Spanish-speaking families to participate in this study, which was really helpful. And I'll give a shout out to my colleagues, Joy Newman and Anna Hernandez, who made that possible. And so the mileage from children's was 3 to 2,033 miles, so a mean of 150 miles. And if you think back to the map that I showed you earlier, I think this really reflects the great distances that folks are traveling to be seen in our clinic in Dallas. So very briefly, we hypothesized that our results that we obtained in face-to-face versus remote sessions would not be significantly different. And that's really what we found, which was very encouraging. And when it came to satisfaction, we saw that, you know, we had people respond favorably. Most people respond favorably to overall, I was satisfied with a video-based testing session. So you can see strongly agree and agree were most of the responses from the parent. And we also had a smaller in white here that you can see that were kind of neutral on that. And our participants were similar in terms of the favorable responses. We definitely had neutral and disagree. And I will say, and if you've ever heard me talk about this study, I always have to share that we had a participant that came from a small town, and this individual let me know that coming to the big city of Dallas meant that they got to go to his favorite restaurant. And so for this reason, he was not as excited about a video session and would have preferred to actually come into the hospital, which I appreciate. But I do think, you know, on a serious note, we always have to pay attention to, you know, those who are letting us know that this may not be the best experience for them, or it may not work for them as much. So to the question, video-based cognitive testing was as acceptable to me as in-person testing. Again, we get mostly favorable responses, 87% of caregivers and 85% of participants, but still kind of a range of responses there. And then to the question, if given a choice, I prefer, our caregivers, 63% had no preference at all, compared to 56% of the participants with no preference. And it was interesting to see that if a person had a preference, our caregivers were more likely to prefer in-person, as compared to our participants, who 26% preferred that remote assessment. And I did dig a little deeper since we put out our paper on this topic, just to look at what were some of the reasons that a person might prefer in-person or video conference. So parents told us it was easier to establish a personal connection, easier to communicate in the same room. We heard both of those things from our patients as well, but they also noted we could avoid tech problems, better environment, and less distracting. So that was interesting kind of takeaways for us to have. And for video conference, when that was a preference, parents were telling us it was easier to communicate over video and they felt less anxious. Those things were echoed by the patients themselves. They also added to that, easier to concentrate without a provider in the room. And video conference made the session more interesting and enjoyable. And I definitely remember talking to a teen about this, who said, you know, it's just better not to have someone kind of hovering over your work or watching you right there so close when doing the testing activities. So I could certainly imagine that. So some conclusions and takeaways. You know, this study gave us some initial support for pediatric home-based teleneuropsych assessment. I think we need more research on this even now, even though, as you'll see, I'll share in a little while, we've seen such an increase in this literature, but we still need more studies, particularly those of validating the measures for use in this setting. So this gives us some opportunities, right, to reach our patients in the comfort of their own home, and to work as researchers as well. I think, you know, we always remain mindful of these limitations and then ethical and practical challenges. So we'll be touching on a variety of these throughout our presentation today. So limitations, there are always limitations, right? So we had a limited sample size, 58 was our final sample size. There were some distractions in the remote environment, which I'm going to get into more detail about that later. We saw variability in tech performance, which makes a lot of sense, right? We were testing kids in their homes, so there was some variability there, and I'll follow up on that and touch on that more later. Our sample was limited in diversity demographically and did focus only on demyelinating disorders. So I think we have some places we can go in the future to really expand on this work. But I wanted to come back to our recruitment. And another place that I've been digging a little bit deeper is around recruitment. We mentioned that we had 62% complete the study. If we look at our actual sample, the sample we ended up with on the left, and then we look at the percentage of total enrolled, it shows us that, we had what I might consider just kind of missed opportunities around our recruitment. So if we were able to retain some of our kind of initially enrolled subjects, we would have really expanded the diversity to a degree, particularly for Black and African American, as you can see in the pie chart on the right. And another place, looking at this again with our actual sample on the left, on the right, we would have expanded slightly our Hispanic participants. And so what happened, right? We looked back at, we keep these very detailed logs of our efforts around recruitment. We had reasons listed for those that, we didn't complete the study with. So we were unable to reach them to schedule. They may have lost interest, didn't show up, maybe too busy to fit it in. Certainly lots of obligations right outside of participating in a research study, and we completely understand that. So work obligations, illness, transportation barriers. So as we think about, who we should be enrolling in our studies, I think as researchers, this is a very big question. It's a complex question. And there are lots of things to think about. We might be thinking about, demyelinating disorders. Do we want to look at the clinic data or prevalence rates and seek to kind of mirror that, or sample a population based on what we're seeing in our clinic? Maybe it's related to regional population or the US population. So not a simple answer, but I think is worth a lot of consideration. We had those reasons listed, but we probably don't know everything that there is to know about reasons we didn't complete the study. And so I think thoughtful recruitment and partnership, with our patients and families in our communities, to work with them on this, to get feedback, and to really kind of enlist them in asking research questions themselves so that we're able to share that back. One of the things that we are able to do in a community of rare disorders, it's a very small world, as you might imagine. And so we are able to share back results of our research with our community through various organizations that we work with, and even in our clinic. So it's really a great experience to go into clinic and see people who I know have participated in various research studies, and to talk about what we found out, what we learned because of their efforts. So, I think this is, there are a lot of takeaways for me here as a researcher to think about, how we might do things differently as we move ahead. Thinking about kind of the larger context. So that study wrapped up in 2019 and was published in 2020. And we all remember well what was going on, particularly at the beginning of 2020. Our field really had kind of a crossroads, as this illustration would suggest, right? So we really had an opportunity to kind of leverage technology, to be innovative, to be creative, to find ways to reach our patients and families who still needed our care. And it was really encouraging and, looking back, pretty amazing to see all of the work that took place during this time. We realized that in addition to all those benefits of telehealth that we've known about for a while, we now had this ability to allow for physical distancing, which was the goal, right? That was everything back then and probably still is in many cases. So there was a webinar in April 2020 that I took part in. And one of the things that came from that, we surveyed the audience to really capture a snapshot of what people were doing when it came to tele-neuropsychology at the time. So in this article, we had this visual that I've shown here, looking at, prior to COVID, what people were doing in the way of teleneuropsych for clinical interview, testing, feedback, and intervention, what people were doing since the beginning of COVID or onset of that, and then following COVID, what were the intentions? And as you can see, the numbers really change, particularly around clinical interview, feedback, even intervention, as it related to what people were doing since COVID began. And then really big intentions for following up and using these tools, even for testing, always testing to a lesser extent than some of the other clinical services listed. So this was an interesting, again, a reference, a point in time to really reflect what the field was thinking and what people were doing at that time. I think what we saw, though, overall was just this incredible group effort to support each other during this really interesting, unprecedented is the word. It was the word of the day back then. Unprecedented time for our field. And so what was really great that we already had in hand were these initial practice recommendations for teleneuropsychology published or led by Maria Grush. And that was a great place to start. They gave us a great framework to then organize some of the interorganizational practice committee guidance. So I think this was a great service to folks, again, during a time where I love the description of, building the plane while it's flying, right? We were just figuring it out. And so Dr. Tish McDonald and I presented at AACN in 2021. This was for the PED-SIG meeting, and we focused on teleneuropsych and really kind of reflected on how far we had come and where we were in relation to this. So we had a prompt for them to think about what words came to mind when they thought about pediatric teleneuropsychology and the COVID-19 pandemic. And I wanted to share this word cloud that was generated during that meeting. And, I think, flexibility really stands out here, which is, I think, what it took to, have that creativity to be innovative, to leverage technology. There was just a lot happening. There were also, there's a lot of fatigue, burnout. I see insomnia on here, anxiety. There was a lot, I think, that it sort of took to be able to kind of move through this, and thinking about our patients and families, the disparities, and we're going to be talking more about that as we move ahead here. So wanted to share that. I also want to show you, and this is a snapshot of the emerging literature kind of by category. So looking at how the literature has grown in this space of pediatric teleneuropsychology, you can see that in the blue and the orange, or I should say the darker blue and the orange, there are more articles representing, discussion of models, putting out models, really and guidance describing kind of lessons learned and what folks were doing around the country and around the world during this time. There are some provider surveys. What you see a little bit less of are those articles around feasibility and validation. But I want to give you a couple of highlights, a couple of examples. Definitely won't have time to do an exhaustive lit review here, but Ransom and colleagues in 2020 provided this retrospective review of patients that were rescheduled from their in-person to Tele-Neuropsych in this window of time, that kind of March through June, where a number of us were not in the clinic, not seeing patients in person. And so, some of their conclusions were around that, these virtual sessions really created a great starting point for differential diagnosis and treatment planning. And then, it was clear that some of the patients really needed more in the way of assessment and required some additional in-person services. Overall, though, there was this thought that there was an increase in efficiency and reduced wait time. So essentially the idea that you're getting to your patients sooner and starting to kind of address concerns faster. And I think that was a really critical piece, especially during this window of time. And then there was another article that I wanted to highlight that kind of, talks about a hybrid model where, so in their study, they didn't do any virtual testing, but really talked about this hybrid model of in-person testing combined with virtual intake and feedback, which you can kind of see here. And I think, this is a model that the more I talk to people and thinking about our own clinic in Dallas, we really are largely back to that in-person testing, but supplementing with our, using those virtual tools for things like interview and feedback. And that seems to be pretty common among my colleagues in pediatric neuropsychology, and probably too on the adult side. Also providing some consultation over video as well. So I think those are definitely areas that lend themselves well to the telehealth environment. But again, there's more to think about. It's not that simple, and that's what some of the next parts of this presentation will address. I also wanted to give you just some examples of those who did some research on different settings and populations. So, again, these articles just multiplying in the context of COVID and following that time. So I think there's still there's a lot of room for more of this work, again, especially on those validation studies and basically, collecting data that really shows the value that's added when we provide a virtual service. We'll talk through some more of these studies, but I want us to all think about this. Virtual services do not work equally well for all. In a presentation, the presentation I mentioned with Dr. Tish McDonald, we included some questions for the PEDSIG to consider at that time. And I think these are really great questions to consider. Things about really access to technology for our patients. So have you ever not had a smartphone with internet in the past 10 years, or been unable to pay a cell phone bill, not had regular access to internet at home, or not had a laptop or computer in the last 20 years? Have you ever had restriction of data usage on a smartphone? So thinking about just the access to technology that would be required to participate in telehealth visits. I do want to say on that note, in our study, 23% of participants borrowed a study device from us. We had iPads, thanks to the funding that we had from the Children's Trust and the National MS Society. We were able to acquire iPads with wireless service so that they could participate in the session with us. Another study highlighted 74% of those interested in telehealth owned a computer with a camera. So while, it's becoming more commonplace for people to have these devices, this technology, we have to remain mindful that that's not going to be the case for every single person. So having mechanisms to assess for that prior to visits, to work with families ahead of time, to, again, determine if they have the technology, or to help them access that if that's a possibility, and it may or may not be. But I would say really importantly, considering alternatives. So I know for a lot of our patient families, just using the telephone has been a great alternative for some of the sessions, kinds of sessions I was just mentioning, from consultation to, interview feedback when that's possible. So I wanted to highlight that. Other questions to consider, and this is again, certainly around access, but thinking about language in this case. So have you ever had to use an interpreter and technology to communicate with a medical provider? Or have you ever had to use a telemedicine or medical record platform in a language you do not read or speak? What about receiving instructions about how to use new medical telecommunication platform in a language you don't read? And so we displayed this just to have participants kind of imagine, trying to navigate a system when you're there to, get help for something that, is going on for you or for your child. Creates pretty incredible barriers and challenges. And I mentioned earlier, 17% of the participant caregivers preferred a language other than English in our study. So I know that when COVID began and we were rolling out our telehealth platforms for clinical purposes, everything we had done up to that point was for research. So all different, using different programs and platforms and things like that. And as we were putting all of this up, one thing we have in Dallas is a bilingual neuropsych assessment program embedded in our larger program. And we worked really hard to ensure that anything that was coming out that was patient facing would be available in Spanish, and that we had other mechanisms, for interpreters and things for our patients as well. So, I think, as I just said, kind of assessing those patient-facing applications, information, and resources is a really critical thing. In addition to language, also considering disability status and how a person takes in information is really critical as well. And then, being aware that technology does not always cooperate and can vary really greatly, especially when you're connecting with someone at home. But I would say, even in large organizations and institutions, we can have tech difficulty as well. On that note, variability in technology performance came up in about 21% of our remote sessions. Fortunately, it was only in one case. It was less than 1% of the data that we collected, kind of the subtests, that we only lost, less than 1%. So that was really great. And I think it was on a session that I was doing where I was administering a math fluency measure, which is timed, right? And so we lost our connection in the midst of that. And so we had to throw that score out, unfortunately. Always in research or clinical care, planning for that lost connection is so big. Knowing what will happen, letting the patient family know, do I want you to log back in, or do we want to get on the phone, or what will we do if that happens? We have found that prioritizing a low bandwidth platform is a great thing. We were able to do that for this study and quickly realized how important that would be. So a few points about evaluating in a home environment. I really think it's important to mention that it's an open window right into the home. And while this may offer some pretty valuable information for clinicians, this may be unwanted. This may not be something that a family is eager to share. And we know that our patients and families, there's a lot going on. In a given household, it might be really hard to find quiet space. So particularly for really any of the sessions we might do, definitely for testing, in the case of our research study, we worked really hard ahead of time to help our participants and families find that quiet space, but it's not always possible. And on that note, we had quite a few distractions during our remote sessions. So almost half we had, and typically they were fleeting and didn't disrupt the session overall, or even, invalidate our test scores, like the lost connection that I just mentioned. But this is a really big thing when you're testing or providing any service in the home environment. So particularly when doing formal assessments, I think tracking those distractions is really important relative to the test list, right? Relative to what you're doing when that happens, much like we might do if we were doing an inpatient evaluation, or if there is a commotion in our outpatient clinics, right? So those distractions do come up no matter where you are, but I just think that the risk is going to be higher outside of that slightly more controlled clinical space that we have. So just want to make a few points on the future as we wrap up here. And I'm going to move ahead quickly, just noting the time. I would love to engage in some kind of question answer time and discussion. I will say that, as far as competency goes in this space, it's really not well defined. And we had to move quickly during COVID and really rely on each other and guidance that we had from those doing this work prior. So I think, consultation is a great thing, continuing education. And as we know, with a Minnesota Update Conference, this is an area that will be a focus in that as well. So we look forward to that. Legislative advocacy for that continued coverage, insurance coverage of telehealth services, I think is just a really big focus right now, to be able to sustain some of the work that's been done and expand on our existing research. I am going to move a little bit faster. I can still see the number of slides I have. But there have been some really excellent outcomes focused studies. So I just want to acknowledge that. And this one showed improved self-efficacy for parents who participated in teleservices, both psychology and neuropsychology services. So I think as we talk to our patients and families about their experiences, this can generate project ideas. There are so many aspects to the service we provide, and so leveraging those, I think, is a really great thing to do. Thinking of telehealth models for specific populations or services, I gave an example of our transition to adult care. Someone's published on that. This is an excellent consultation model that centers around looking at learning disorders in children and adolescents. So, it doesn't have to be testing, right? It can be a whole host of other things that we bring to the table. And so evaluating barriers and disparities and addressing these in the research work that we're doing. Validating new measures for remote assessment use, as this group did. Hamner and colleagues is a great article. If you haven't seen these, please check them out. And just kind of in conclusion, I think that we've had an unexpected acceleration, to say the least, and we're seeing some great work that has come about as a result of this. And I think our challenge right now is to keep this going, is to keep this research coming out, to continue to support and sustain what we've done so far, and to compel our payers to see the value or to pay for this and to see the value of the services that we provide. So I think I've made these other points already. So I'm going to acknowledge several groups and colleagues who made this work possible. This is all a team sport, right? When we get into research and all of this exciting work. So thank you so much for having me. I'm going to stop sharing so I can see what's going on here. Okay. Thank you so much.
Thank you, Dr. Harder, for such a phenomenal lecture. This was really great. I mean, it was so comprehensive, from talking about access to diversity to feasibility, models of practice, and even sharing some nice readings with us that we can definitely do. I personally was familiar with some work, but I didn't realize that the literature was growing so quickly and in so many different areas. And I think, when you have this almost like a new field, but a new area, it's so important to have everybody working together, like you said, to be able to research all these areas so we can put it into practice. We have lots of questions because this is really exciting. So let me just get those pulled up here. So I think, one question is, how do you ensure that kids are paying attention / giving full effort? How can you keep them engaged when they are using the screen?
That's an excellent question. I actually think that is a brilliant subject for a research project around effort into a telehealth setting. I will say that, much like in a clinical situation where we're face to face and we're working with our patients, I mean, it is different being on a screen, but I found that a lot of the kind of behavioral and engagement kind of efforts that we made were pretty successful. And I think that the kids found the technology piece to be a little bit more novel and engaging and interesting. I can remember times when the iPad was bumped, let's say, and I was looking at a ceiling fan for a while. So there were times, but by verbal redirection, I was able to kind of get us back to where we needed to be. So I was using a lot of the same skills I use in the room with the patient. And what I had as my backup was a way to reach the parent immediately if I needed them to come and kind of help me out. But they were otherwise outside of the room. And again, we went down to age 6, so we were able to go pretty low in terms of age. So I hope that answers the question, but I think we could definitely use some research around that kind of effort and effort testing in the context of a telehealth model. Absolutely.
That definitely sounds like a great research project or dissertation if anyone needs one. But I think, like you said, speaking to using the skills that we're already using right now for behavioral management, things like that. And I wonder if part of it is the population as well. Potentially with patients with demyelinating diseases, you're not seeing maybe as much hyperactivity or as impulsivity, somebody that's as rambunctious as if you're doing some type of ADHD evaluation.
That's an excellent point. And another thing we didn't really explore, again, another great subject for a project would be a wider range of cognitive ability. So in demyelinating disorders, there's, most of the data out there suggests that, overall cognitive ability is broadly within expectation. Of course, there's always variability there, but that's another piece to acknowledge too.
Yeah. And I think, looking at your battery, I think one question that came up was, obviously there's more verbal based measures and things that can be administered, orally. But I think there were some measures that do require some, for example, calculation or the VMI, math fluency or reading fluency. How did you provide those materials to the families, or were you able to set something up on the screen?
Yeah, great question. And definitely folks are paying attention to the details and imagining how would you do that. So we actually worked with publishers and got permission to reproduce certain things to be able to share. So I'll give you an example. So Riverside worked with us for the WJ so that we could recreate those word lists and things that they needed to be able to read. This was using WJ3, by the way. It's not the newest one, but so we were able to reproduce those, and we gave a packet to the families. We either mailed it in priority, mail, and tracked it, or we gave it to them at their in-person visit to then use in the virtual visit. We had them not open it until we started the session, had them seal it as we're finishing the session, and then send it back priority mail. So we were able to do all of that because of the funding. But things have changed so much even since then, where there's actually more tools to administer tests, working with a publisher and getting access to that material, and to do screen sharing, which we did not have in our the platform that we used. So that was how we accomplished that.
Yeah, and that's another question that came out is, now, for example, with the WISC, you have these, I think it's with, you can have all the stimuli essentially on, virtually uploaded. So we're curious about, with your teleneuropsychology testing that you had done for this research in the past, and now how you're doing it, have you noticed any changes in your administration, something that you're doing differently, or things that are still the same and they work? Just thinking about the progression of administration and selection.
Yeah, and I think there has been some nice progression. If I were to do it over again, I would not be mailing things and going that route. It was just a lot of labor. It was labor intensive to do that. So I think now with the tools that we have, right, we're able, like you said, we're able to show things on the screen and to do things in a different way than we were able to back then. So it's definitely changed, and I wouldn't want to go back to sending paper materials. And I don't think we want this to be feasible and, something that people could replicate or do, and that doesn't take too much in the way of resources and effort. So,
let's see here. So another specific question, how could a clinician address differences in access to technology, stable Wi-Fi, quality of technology? And then what should a clinician do if a child logs on and the clinician realizes that they're using a cell phone, or if their Wi-Fi is lagging? I think you spoke a little bit to the protocols that you had, but if you could expand a little bit maybe on that.
Yeah. So a few different things there. I think the point about like logging on and realizing the technology isn't where it needs to be for what you're doing. So cell phone, for example, in our study, no cell phones were allowed because we needed a larger screen to be able to see the child and show them things that, so I think for testing, that becomes more important, the larger screen size. I think, to the extent possible at the point of scheduling, kind of assessing those things, or training, the scheduling team to be able to ask those questions. Now, it's going to be hard to assess, Wi-Fi and like the strength of the connection and things. And also we know that I'm no expert in IT related things, but the more people on a network, the slower it might go. And so I can recall a family from a rural area, they were having to, yell at a sibling in the other room to shut down their gaming until we were done. So, and I think, I've heard stories like that from the pandemic period where everybody was at home logged on to the network. So I think that's where the point of like switching gears and finding an alternative, providing the service that you can provide in that moment. And so if it's switching to phone, which I've definitely had to do, and then making a new plan. If testing is the goal, that would be a different plan. If it's feedback or an interview or consultation and you can switch to phone and still provide that service, then that's a good thing. But just think that, problem solving and troubleshooting, but you also hope that, at the point of scheduling, you're finding out some of the key pieces ahead of time. Like if you don't want them to be on a cell phone, for instance.
Right. It's kind of what we do in terms of controlling our environment as much as we can, just making sure we're taking that extra step to do that for the external environment that they're going to be in.
Exactly. Yes. Yes.
Um, Another question, it sounds like one of our attendees, their lab has started using some Zoom research testing, and they've run into some issues with participants Googling answers for vocabulary on the WASI from home. So they're just curious about, how can you make sure people aren't using other resources on assessments?
Yeah. Oh, that's a hard one. I have heard of some people, and we have not done this, but I have heard of people employing like a two device approach
Mhm.
where they can see a different view of the patient, in addition to kind of like we're interacting right now, but they're then able to see the environment to ensure that that's not going on. But yeah, that's a tough one. And that, two device, I mean, we were just talking about having one device, right? So, having two is a higher bar and might be more difficult. Other things are, asking them to shut down all other programs. I mean,
Mhm.
I don't know, I guess with Zoom, there, and I'm just starting to brainstorm right now, but there's the ability to screen share, but I don't know the ins and outs of that, and if that would completely prevent the issue. But
Yeah.
that's not one that's come up, and I'm glad that that was raised because I want to give some thought to that.
Yeah, definitely interesting. And I know that some of our test security can be getting a little bit less secure with some websites that are kind of
No doubt.
coaching people how to take our assessments and things like that. I think that's just another consideration that we have to have when we're working with patients, whether it's in person or remote.
Sure.
Another question was related to, let's see, I think I lost my spot. Sorry. Oh, sorry. So which domains do you feel like are easiest or most difficult to assess via teleneuropsychology? And how do you think clinicians can address those areas that are harder?
Mhm. Yeah, this has given a lot of thought to this one. So, especially as we moved from research over to clinical, we developed a modified battery that would not involve all that back and forth with mail and things like that. So, I think we've mentioned those auditory verbal measures are probably the easiest. So you're just really, kind of talking, question answer, or reading word lists or whatever that might look like. I think the things that are harder, and I give this example, just thinking about, we really like to give fine motor dexterity type measures for demyelinating disorders, because this is an area where, there can be difficulty there. But I'm not going to ship a grooved pegboard or, like that just, it isn't really possible. But this is where I think like the innovation could come in, and I think there's the technology now to measure fine motor movements and to track those things. I haven't seen anything in the neuropsych space yet, but I think that technology or that innovation is there or would be available to us. Where we've tried to get creative, we've had just on the clinical side, had our patients, do a writing sample of a few sentences and kind of show us that and capture the image. But yeah, those, I think, fine motor, I mean, also think block design, like how does that happen?
Mhm.
Right. So at least for the traditional approach that we all think of. Yeah.
Yeah, I think that's key to this traditional approach. So if there are new technologies that are measuring fine motor skills other than our good old group headboard, maybe that's something that we can switch to.
Yeah, yeah. So another area that's wide open, I think, or ways to track, graphomotor handwriting movements. I think all of that is there. But I have not seen that incorporated so far, but would love to hear about it if it's out there.
Yeah, well, hopefully someone will get to work on that, or
Yeah.
I'm sure now the door is open. The floodgates have been opened, and now
Mhm.
more research is emerging, and it's
Yeah.
so great that you have been able to pioneer this to support these patients and families, especially regarding access. That's so important. And just thank you so much for your time. We're a little bit over, but we appreciate all of your insight and knowledge on this topic. So thank you.
Well, thank you again for having me. This was great.
Great. Take care. Bye.